presentation.
Thank you.
Will we go on to the next presenter, which I think is Danyal Z Khan?
Yeah, hello. Can you guys see my screen?
Yes, we can see your screen there, so
right.
Feel free to start.
All right, thank you. Thank you for the opportunity to talk today. My name is Danyal Khan. I'm a clinical research fellow at Queen Square in UCL. I'm here today to present some work I did during my time at Cambridge, and it's a pilot study looking at patients with concussion on trying to understand their underlying cerebrovascular autoregulation, and we're using a novel robotic transcranial Doppler system to assess that. So in terms of the background, so these patients tend to get a constellation of physical, emotional, and psychiatric symptoms labeled as post-concussive syndrome. It's classically after mild TBI, but in reality, it's after various spectrums of TBI, up to all the severe forms. Now, the problem with this is it's considerably variable in terms of its prevalence and clinical course. And what really this stems from is the etiology of PCS. We don't know. It's heavily debated. And actually, one of the schools of thought is that impaired control of your cerebral blood flow, a term we call autoregulation, contributes to this complex syndrome of symptoms. So a little bit about autoregulation. One of the forms is pressure autoregulation. And we've all seen similar graphs like this throughout medical school. But essentially what this is saying is that within a certain range of blood pressure, the brain and its vasculature are able to control a constant flow and controlled flow through its system. Now, what's important to note is outside of these parameters, it's almost proportional, but within this physiological range, it's controlled and constant. Now, the useful thing about this metric is that we can measure this non-invasively. So the cerebral blood flow we can measure using transcranial Dopplers, which I'll go on to more in just a second. Whereas the blood pressure we can measure using these little finger blood pressure cuffs in a process called plethysmography, which again I'll explain in just a moment. Now, using these two metrics, we can perform a number of calculations, one of which is called NMXA, and the other one is called transient hyperemic response ratio. So what is NMXA? I don't think it actually stands for anything. It's not an acronym, but rather it's come through multiple iterations of this correlation between blood flow through the brain and systemic blood pressure. And it's the mean blood flow and the mean blood pressure that we're looking at. And simply put, it's a Pearson correlation coefficient. And when we reach levels above, so positive 0.4, it means that we're seeing a proportional relationship between blood pressure and flow. And we know, looking at that previous diagram, that contradicts the ability to autoregulate. Now, the next metric is the hyperemic response ratio. And you can see along this bottom graph, you can see the flow through the cerebral vasculature with these systolic peaks. And you can see the sudden decrease in flow. And what's happening there is we're compressing some of these carotid artery proximal to the cerebral arteries that we're insunating. And you can see then underlying that, the vasculature will vasodilate, as is a common physiological phenomenon. And when you re-establish flow, so release the compression at the neck, you see this hyperemia afterwards. And simply put, this metric is the ratio of change from the hyperemic response to the baseline. And a number of greater than 9% is said to be normal. Now, based on these metrics, we decided to perform a pilot study looking at these ways to measure autoregulations in patients with symptoms of post-concussive syndrome. And the key to this was it's prospective, non-invasive, and in a real-world setting. So we performed this in our outpatient clinics before the pandemic. The key part of the first stage of this study was looking at the feasibility and acceptability of this work. So in terms of our setup, it's all on one trolley. You can see that there's a full trolley with multiple levels. The robotic Doppler system, which is kindly provided to us by a company called Delica, is novel in that it's seated on a headband with these housing probes. And in contact with the head are these little robotic probes. And they're very clever. What they're able to do using semi-automated processes is pick up where it has to point to find the optimum waveform from your middle cerebral artery. And it also tracks that. So if the band moves at all, it's able to track that and maintain high quality data coming through the system. The finger plethysmograph is in this bottom right hand corner, and simply put, it's a blood pressure cuff. I think of it like a non-invasive arterial line. Now, the key parts of this, as you can see, it's on wheels, so it's portable, we can wheel it into clinic, and it's totally non-invasive and painless. Now, in terms of our processing, this is the Doppler waveforms that we get from the Doppler system, the Delica system. Then we've got the PhenoPress plethysmograph waveforms. And the master computer to this is a system called ICM Plus, which is bespoke to this analysis and helps us calculate MX and THRR, the hyperemic response ratio. A sneak peek at our results. As I said, this was a pilot study. You can see a male predominance that is classic with TBI, a various spectrum of severity of TBI, and a various spectrum of post-concussive syndrome burden using a standardized scale. Now, the key thing here is the feasibility. So we were able to calculate NMXA in 90% of patients. Only 50% we were able to calculate the hyperemic response ratio. And that's predominantly due to the actually anatomical difficulties and probably a learning curve in my circumstance in terms of achieving the correct amount of compression. As you all remember, the carotid is kind of deep within the carotid sheath, and actually it's quite mobile, and it can be uncomfortable to some. So it's a tricky technique to refine and produce reproducibility in. Patients found it acceptable. For all intents and purposes, they're lying down with this headband on and a blood pressure cuff on, watching Netflix on my iPad for an hour, so it's not too bad. But there are some areas for improvement. For example, when we tighten this headband very hard, the probes actually press in on the temples and can cause a headache if left on for something like an hour's time. So there is scope to make this more comfortable, make it so that we can secure the probes without causing too much pressure on the head, and also reducing the time that we require to get enough data. And that'll be through improving our robotic tracking functions and our data analysis functions. So in conclusion, we demonstrated that we're able to produce reproducible, non-invasive metrics for cerebral autoregulation in a small group of 10 people. It's acceptable to patients, and we're able to use it in the outpatient setting. And that has real potential for scaling this up. But of course, that'll only be when it's safe to do so. And we've had to adapt our study in light of the pandemic, but we hope that when it is safe, we'll be able to restart and hopefully make an impact to these patients that otherwise don't have an answer for why they have these constellation of symptoms. The end goal of this would, of course, be to produce therapies that can modulate autoregulation or blood flow through the brain to improve this patient's outcomes and morbidity. So I'd like to just place my acknowledgement slides here, and I'd be delighted to take any questions.
Brilliant. Thanks so much for a really interesting talk. I suppose you've kind of said that you can see the value in terms of therapeutics.
Yeah.
That's obviously perhaps further down the line, because I suppose even at this stage, it's just sort of establishing that this relationship exists,
yeah.
and I'm sure much more work to get it to the stage where you can intervene. Do you see any more sort of any in the nearer future, any use for it in terms of perhaps stratifying severity or identifying patients for additional follow-up and that kind of side of things, or do you see it's only for this sort of intervention purpose?
Yeah, no, you're 100% right. So there's many ways we can go, and actually when we were applying for money for this, we kind of pitched it as that. So it's a way to get an objective metric in this otherwise heterogeneous group of population. Mild TBI makes up the overwhelming majority of TBI patients. And actually, in terms of clinics and the people you see in clinic, it's this mild to moderate group, which we don't really have much therapy for. I mean, our allied healthcare professionals, like psychologists and occupational therapists, do a great role, but medically it's really challenging. And so perhaps, I think you're very right, if we can stratify these into, okay, these are patients with particularly high symptom burden, they need to be integrated with X, Y, and Z service. We know that patients falling within this category benefit the most from those services. And similarly, those patients would need increased frequency of follow-up. It might be interesting to follow up with advanced imaging in those patients as well, which is another way, another school of thought is using advanced MRIs, arterial spin labeling to look at these patients. So I think there's potential basically to categorize and define this very heterogeneous group, and then diagnostically, management-wise, and therapeutically come up with ways that we can help.
Yeah, fantastic. Don't think there's any further questions there, so I think we'll move on to the next person, if that's all right.
Thank you for your time.
No, thank you for your presentation. So now we've got